Jen, unmute yourself. Why I cannot? Is agenda? Can you see the agenda? Hello, Rohan. Yeah. Welcome all of you to today's Neboy classroom. I request President BK Das sir to start the program. Over to you, sir.
Please unmute.
Please unmute yourself.
Yeah, we cannot.
Now stop this agenda.
Stop sharing the agenda, please. Okay. Is it visible?
Yes.
Yes. Suresh sir?
Yes.
This is our room as an academic program for an northeastern branch of UI. We have invited the national faculty, Dr. Srinivas Dorasala, and our speaker from Northeast, Dr. Supriya and Dr. Smriti. And it will be moderated by our Nabai faculty. So I welcome you all to this event to make it success for Nabai, and it should go to all India level. That is the thing. So welcome you all. Thank you. Thank you very much.
I request Dr. Sagata Khanna ma'am to introduce our special guest and as well as speaker.
I think Dr. Anjan Jyoti Bhuya will introduce our guest faculty. Can
Yes,
you
ma'am.
can you
As
please?
he is not present till now, should I start with as soon as he comes? It will be better if you can introduce the other two.
Okay. So okay. So welcome all to this Naboy classroom, and we hope this classroom will be very much interesting. So our speaker for today's classroom is Dr. Supriya Singham. So her short bio, that she has a brilliant academic career. She passed her MBBS from Swami Mansingh Medical College, Jaipur in 2004 and completed her MS in ENT from King George Medical University, Lucknow in the year 2009. And she is a very talented lady. She received Pandit Govind Prasad Shukla Gold Medal Award for Best Postgraduate. She worked as an ENT consultant in Shija Hospital and Research Institute in Imphal, Manipur for 9 years. But from 2020 onwards, she is working as ENT consultant and facial aesthetic surgeon in Niruja Clinic, Imphal. She has her own vertigo clinic with VNG setup at Niruja Clinic. She is also trained in open rhinoplasty under Americo Roberti in Italy in 2017. She underwent training in reconstructive and aesthetic surgery of nose and face in Netherlands University. She also attended masterclass in vertigo by Michael in Philippines. So she has a very brilliant career. So we hope she will give us a very good idea about the balance mechanism and outcome. Our moderator are Dr. Smriti Rupa Bora, doctor. She is presently Professor and Head of the Department of ENT and Head and Neck Surgery, Silchar Medical College Hospital, and Assam, from Assam. Her notable achievements are she received LH Hiranandani Award. Also, she received SN Sharma Award. She presented her research paper in SAG conference. Also presented research paper in PAFA's Plastic and Reconstructive Surgery annual conference in February in New Delhi. She has several publications in national and international journals. Also, she presented podium presentation in national and international conferences. Her areas of interest is endoscopic sinus surgery, maxillofacial surgeries, and thyroid. So we welcome Dr. Smriti Rupa for this classroom. Another moderator of this session, Dr. Surojit Burman. He is a now national faculty for this neuro-otology section. He is a presently he is a consultant of neuro-otologist in the Center for Balance Disorder and Rehabilitation at Guwahati. He is elected as a Vice President of Neuroecolobiometric Society of India. He is a faculty and certificate course in assessment and management of vestibular diseases at DIM University. So we welcome Dr. Surojit Burman to this our classroom. We hope there will be a very interesting session, and all the participants of this classroom will take part, and hope they will be benefited. Thank you. May I now request Dr. Supriya Singham to present her.
Srinivas is there. You can introduce him.
Yeah, yeah, okay. Very good. Welcome. Yeah. Dr. Anjan Jyoti, you can introduce about Dr. Doresala. Yeah, Srinivas.
Welcome everyone. Dr. Srinivas Doresala need no introduction. So we all know him. He is one of the most talented and most known figure in national or international level in our age. So today it's my proud privilege to introduce read few lines about Dr. Doresala. He is presently is a consultant at Ananya Healthcare, honorary professor at Jawaharlal Nehru Medical College, and adjunct faculty at Unipua Medical College. He has been awarded the inaugural Dr. P. Ghosh Award for Innovation in ENT by Delhi State AOI. He introduced, though we all know he's a vestibular specialist, but this part is not known to all. He introduced microvascular free flap surgery at MS Ramaya Medical College, had a special interest in complex airway surgery, and contributed towards the establishment of cadaver-based advanced surgical skill lab at MS Ramaya Medical College. His first key innovation is a true point of care vestibulo-nystagmography system, which has more than 700 installations across globe so far. He has also introduced point-of-care high-precision posturography with robust diagnostic and rehabilitation module for easy, accurate, and rapid assessment of functionality of 6 semicircular canal. He has introduced a functional head impulse test device as a new advancement in the traditional video nystagmography. He has introduced cranio-oculography, which adds head movement measures in addition to eye movement measures. He runs the 3-month mentored learning course in Vertigo for ENT, neurology, audiology professionals. So far, more than 700 doctors and other professionals have completed the 3-month course under his mentorship. So I welcome you, sir, for our special classroom held by the NEBAOI Scientific Committee. So we are looking forward for your participation in this lectures.
Sir, half the
Thanks
time has been finished in my introduction. Next time, don't make all this big introduction. Okay, I'll keep joining every month. Okay.
This is needed for Indian, sir.
Yeah. Now we have to give it to Supriya.
Yes.
Hello, sir.
Yes, ma'am.
I would like to share my slide. Is my slide visible?
Visible, visible.
Yes.
First of all, a very warm evening to one and all. I am indeed honored to be a part of this NEBAU classroom. And the topic of my presentation today is on anatomy of the labyrinth and pathophysiology of BPPV. The glamorous part of BPPV is not included in my topic, since it is the thing I will be covering is anatomy and pathophysiology of BPPV. However, I'll try my level best to make it an interesting presentation, and understanding of it will help us deal with many vestibular disorders that we will come across in our life. So first of all, why we are giving the name labyrinth to the inner ear? That is because of its complex structure, since labyrinth means complexity. So it has two parts, the bony part and the membranous part. The bony part, it consists of series of bony cavities which are contained in the petrous part of the temporal bone. The membranous labyrinth, it consists of membranous sac, that is the utricle and the saccule, and a semicircular canal, which is contained in the bony canal by the support of trabeculae, and it occupies only about 5% of the diameter of the bony canal. Two types of vestibular sensors are there, and that is the semicircular canal, which detect the angular acceleration, the otolith organ that detect the linear acceleration and the gravity. The semicircular canal and otolith organ, they are oriented inside the body in such a way that it corresponds to their action. Coming to the orientation of the semicircular canal, its canal lies close to a single plane. For example, the horizontal canal makes an angle approximately of 20 degrees with the Earth's horizontal plane. And seeing from the top, the anterior, the posterior, and the other semicircular canal, they make an angle of 45 degrees with the sagittal plane or the coronal plane in such a way that they can make an orthogonal pair to each other or one another. So each pair is nearly parallel to each other. For example, the left anterior canal, it's almost parallel to the right posterior canal, and the left posterior canal is almost parallel to the right anterior canal. The horizontal canal of one side is almost parallel to the horizontal canal of the other side. This orientation helps act in such a way that when one part of the pair is excited, the other part is inhibited. This arrangement helps in detecting movements in all the plane, that is the yaw plane, pitch plane, and the roll plane. Now coming to the orientation of the otolith organ, the utricle has a predominant horizontal orientation and the saccule has a predominant vertical orientation, resulting in detecting movements in the horizontal and the vertical plane. The three semicircular canals, they are connected to the utricle through a dilated end and as well as a non-dilated, non-ampullary end. The non-dilated end of the anterior canal and the posterior canal, they are they combine together to form the crus communi, and they all open together into the utricle. So altogether there are 5 openings into the utricle. That is the 2 from the horizontal canal and 1 each from the anterior and the posterior canal, and a combined canal, that is from the combined canal of the anterior and the posterior canal. Why this is important is because the lining epithelium of the semicircular canal is usually the squamous epithelium, and in certain areas this squamous epithelium is specialized into neuroepithelium, or we can say the vestibular sensors. So the ampulla, that is a dilated end, houses the neuroepithelial region of the semicircular canal, and we call it the crista ampullaris. Like that, in the otolith organ, the counterpart, that is that are specialized into neuroepithelium is the maculae in the utricle and the saccule. So the location of the sensory canal and the sensory receptors of the semicircular canal is in the ampulla, and the otolith organ, the sensory receptors is the maculae. The utricular maculae is located in the anterior wall of the utricle. Saccular macula is located in the infero-medial wall of the saccule, and in both the sensory receptors, be it the semicircular canal or the otolith organ,
Supriya,
Supriya sound नहीं क्या लो?
Supriya,
Internet का
ফোন কৰিব লাগিব নেকি?
what the issue in the internet connectivity?
এবাৰ ফোন কৰি চাওক নেকি? Supriya, are you here? এইখন কাৰ? হা? এইটো কাৰ স্ক্ৰীন? অঞ্জন বাবু এবাৰ ফোন কৰি লওক নেকি?
मैं मारी है बिजी है
I'm trying her phone, but
Even I tried her, but the phone is showing not reach. I mean, she's not
busy
picking up.
busy
No, it was ringing when I tried first, but she's not picking up.
I think she's taking the mobile network for
busy
Supriya. What happened to your network?
yeah, actually the light went off. So I'm
Oh.
trying to connect it.
Okay, once you connect, just give a voice call. You just let us know, because we want to make it co-host so that you can share your slide. Okay.
Actually, network should be either it should be connected with inverter actually, line. Then when it goes off light, then inverter take up.
I think I'll just take 1 minute time when we are now waiting for Supriya to join in to welcome Dr. Pratik and Dr. Parvesh, who has also joined us. So welcome to both of you. I think there are many more, but these are the two names I saw. Dr. Pratik Porwal and from Hardoi near Lucknow, and Dr. Parvesh is from Chennai. So welcome to both of you.
Actually, we did not make it visible in the national forum. No, we can, I think, these things. So many people can join in YouTube also.
Pratik, welcome to our Nevoy classroom.
Hi, ma'am.
Yeah. Sorry for actually, no, she was from Imphal. I think some network issue is there. She'll be joining soon. Please bear with us. Sir, please unmute. Sir, please unmute yourself.
By then, I think Surajit can continue the presentation.
Yes, Surajit, please.
Now we'll just wait for 1 or 2 minutes for Supriya to come in. She has put in a lot of effort for her presentation.
Yeah.
And just a thing for everyone. Anybody has any questions, you can put up in the chat box. And end of the Supriya's talk, we will have discussions on any topic. And today we are lucky to have so many stalwarts, except we of course have Dr. Srinivas with us, we have Pravesh with us, we have Pratik with us, with all so many big names here. I think every PGs and everybody who has any interest in neurology should come up with a lot of questions. We have great minds to answer our questions today. So this is a open invitation to all of you. You will not get a better chance than this to get your doubts cleared. And I think Swagata ma'am and Anjana ma'am will definitely increase a few minutes at the end of the thing to hear from these great people. So Supriya is back. We'll go back to her.
Dr. Rohan, can you make her co-host?
I think Dr. Supriya is now available.
Yeah.
Yes.
Yeah.
Actually,
Dr. Rohan,
light went off.
can you make her co-host? Dr. Rohan? Dr. Rohan?
Done, ma'am.
Okay. You can share your slide.
Yeah. Continue.
My slide is visible.
Yes, visible.
I don't know from where to start. My light went off, so my connection was also off.
So Supriya, if I remember correctly, you were talking about the orthogonal planes that the angulation of the canals come up with. So you can start from there again.
So it's done.
This is done.
Yeah.
Pardon, I cannot hear. From where I should start?
From the Supriya, can you hear me?
Yeah, I can hear you.
So
Yeah,
you can
next
start from
slide.
the orthogonal planes you were talking about that the canals make. You were around that time we started missing you.
No, you can skip this slide.
Yeah, you can skip this.
You
Skip
can
this. You have done this.
skip it.
Next slide, please.
I think from here.
I think her network is a bit weak.
Okay. Is my voice breaking?
Yeah, and
No, it's coming perfectly.
I mean,
It's
you
coming
just continue.
Okay.
You can start second part
Yeah.
of.
Yeah, I was talking about the type of the vestibular cells that are present. That is the type 1 and type 2. Type 1 is usually the flask or goblet cells, and they are located centrally. They are found in advanced animals like land animals. And type 2 cylindrical, they are mainly located periphery. Here, mention can be made about the short arm and the long arm of the semicircular canal. They are the ampulla that drains into the utricle. This is the long arm, and the short arm is the ampullary side of the utricle side of the ampulla that drains into the utricle. This is the short arm, and the short arm and long arm of semicircular canal is very much prominent in posterior canal compared to other canals. Coming to the orientation of the hair cells in otolith organ, the utriculus, they are
The internet is bad.
he has a very bad network, I think. What to do? Surajit, moderator, please.
Yeah. Madhu.
What to do?
I think we have many experts available here in this platform tonight. So maybe our PGTs would love to hear from them.
See, hello.
Yes, sir.
Good evening, sir.
Good evening, ma'am. At least there is one lesson that we have, because this is the beginning stage. It's a good idea from now onwards to start having one version of that talk being pre-recorded and sent to the organizer.
Yeah, we have to do that.
Yeah, from next meeting onwards, we will ensure that one thing is because internet is never believable.
Yeah.
So we'll make it a habit that we'll pre-record and we will send one version and present. But if the internet is a problem, then we can always play it from the organizers.
Yeah.
In the meanwhile, till she joins in, I think we can have a open house and start discussing. Okay, and then I think Surajit is there, Anjana ma'am is there.
I request Srinivas sir to start with the topic, sir.
So, Srinivas sir,
Yes,
there's an observation from SB Fukan sir. He says secule as a part of the audio connection may have a role in Tullio phenomenon. Is that the explanation? So, do you have any comments on that?
SACULE as part of audio connection may have a role in Tullio phenomenon.
Is that an explanation of Tullio phenomenon? Is what he wants to know, or what he wants to point out? So, what do you want to say something on that?
See, this is SACULE definitely has audio connections. That much is true.
So, does that audio connection in the SACULE play a role into Tullio phenomenon? Is what we want to know.
Now,
Are these two related?
1 minute, I'll just put my AirPods. Okay, I'll just put my AirPods
Okay.
because there's a lot of background noise here. Okay.
Yeah, I can see a video of some romanticism going on behind you.
Can't hear you, sir.
See, don't blame me for what is happening behind me. Only what is in front of me, you can. Okay.
I request the PGTs to come up with their queries and type your questions in the chat box.
Hello?
Yes, sir.
Sir. Audible, sir.
Yeah, now I am on airports, so I can hear you better because there was a lot of background noise. I hope you also are not getting that background noise. Sorry. Yeah. Surajit boss, I think your question was related to audio connections of the SACULE and
Yeah, this is something that was put up by Fugan sir. He says that the audio connection of SACULE, does it have any role in the Tullio phenomenon?
I really don't know. I'll have to check. But Fukan sir has asked means he already knows the answer and he's just testing us. Fukan sir, you should only tell us the answer.
Fukan sir, please unmute yourself.
No, actually, I found it somewhere that in the third window, that the Tullio phenomenon, that yes, the developmentally SACULE has got a relationship with your hearing, cochlear part. Therefore, when in the Tullio phenomenon, when the sound get more increased with the vertigo, that is therefore they think that it can be explained like that. The Tullio phenomenon can be explained like that. This is probable, I don't know, but
it is quite possible. Okay, it is quite possible. And this thing, I know. See, but my other question also, my other assumption also right. You know the answer already.
Yeah, correct.
Yeah.
Not tested, but you are great.
Yeah.
Okay, Supriya is back, so I think we can go back
Yeah, yeah.
to
Yes,
Supriya.
yes, yes, yes.
I really beg your pardon because of the, electricity. I have to waste a little bit of time.
It's okay, Supriya. We understand your issue. Continue, please. Don't worry about that.
Slide. From where I should start?
Yeah, you can start from here.
Yeah, from the supporting cells.
Yeah.
I think.
Yeah, this from here.
Yeah, I was talking about the supporting cells of the neuroepithelium, that neuroepithelium of both the otolith organ as well as the crista ampullaris. We have a supporting cell made up of gelatinous structure, which we call it cupula for the semicircular canal and otolithic membrane for the otolith organ. And in otolithic organ, the surface of this otolithic membrane is covered by a blanket of rhombohedral crystal called otoconia or statoconia. The cupula is equal in density to the surrounding endolymph and does not exert a force on the hair cells. Its position is changed by the movement of the endolymph within the canal. Here, one important thing that has to be mentioned is that the cupula is a complete diaphragm and cannot pass from one part of the canal and to the other side of the canal. It is a complete diaphragm. And the fact of which it helps us to describe the movement of otoconia while doing maneuver. So when the otoconia is present in the long arm of superior canal, anterior canal, lateral canal, or the posterior canal. For the otoconia, for the maneuver to be correct, the flow of the otoconia cannot pass beyond the cupulary, cannot pass through the cupula to reach the utricle. So it has to be ampulopugal flow in every time. So while we do the maneuver, we are confirmed that the maneuver is correct or not by this knowledge. That is, for example, in a vertical canal, while doing the maneuver, if the patient complains of more nystagmus, that is excitatory state, then it means that the maneuver is correct, because ampulofugal flow should be the correct movement of the otoconia during maneuver, and ampulofugal flow is excitatory in vertical canal. However, in the horizontal canal, the ampulofugal flow is inhibitory. So if the patient complains of intense vertigo during the maneuver, then that means that we are doing the maneuver in a wrong way. So so this is the thing. And now coming to the excitation and inhibition of the hair cells. The hair cells, which I mentioned earlier about the flash shape, the type 1 and the type 2, on the top of the hair cells, they are kinocilium, which is flanked together by a group of stereocilia. And the stereocilia are arranged in such a way that they are arranged according to the height or in the rank order. And they are connected from one to another at the top by tip links. This arrangement is important as it makes the cell polarize in the same direction. And another important point of the tip link is that it is a proteinaceous structure and it is linked to an ion-gated channel. And this ion-gated channel, due to the movement of the hair cells, the movement of the kinocilium and stereocilia, it results in the opening and the closing of the ion channel. So in the resting phase, these ion channels are partially open up and a resting membrane potential is present. When the movement of the stereocilia is towards the kinocilium, the tip link, which is linked to the potassium channel, is stretched, resulting in the opening of the channel get completely, resulting in depolarization and excitation of the hair cells. So movement towards the kinocilium will result in the excitation of the hair cells. When the movement of the stereocilia is away from the kinocilium, it results in the closure of the channel gate and results in hyperpolarization and hence inhibition of the hair cells. So now we understand why the ampulopetal flow is excitatory in horizontal canal and why ampulofugal flow is excitatory in vertical canal. That is because of the arrangement of the kinocilium. Since the kinocilium is placed towards the utricle in the horizontal plane, so ampulopetal flow is excitatory in the horizontal canal, and kinocilium is placed away from the utricle in the vertical canal. So ampulofugal flow is excitatory in the vertical canals. Now, next important thing which we should understand is that the semicircular canal is functionally paired with the extraocular muscles. They are believed to be developed embryologically together and they perform the same action. So the canals lie roughly in the same plane as the extraocular muscles. The vertical canal is almost aligned to the superior and inferior recti muscles and also the oblique muscles. And the horizontal canals are combined to the aligned to the medial rectus and the lateral rectus muscle. So each canal excites a pair of muscles and inhibit a pair of muscle in its plane. Its partner excites the muscle, it inhibits, and vice versa. So the posterior canal, when it is excited, then two pairs of muscles, that is the ipsilateral superior oblique and the contralateral inferior rectus, will act. When it is inhibited, the ipsilateral inferior oblique and the contralateral superior rectus will be inhibited. Likewise, the horizontal canal, when it is excited, ipsilateral medial rectus will be excited and the contralateral muscle, that is the lateral rectus muscle, contralateral lateral rectus muscles will be inhibited, and vice versa. In the anterior canal also, when it is excited, then the pair of muscles, that is the ipsilateral superior rectus and the contralateral inferior oblique, will act, and in the inhibited form, when it is inhibited, the inferior rectus and the superior canal is coupled with specific extraocular muscle through the vestibular afferent to activate one ipsilateral and one extraocular muscle. So the horizontal canal is responsible for the horizontal gaze, anterior canal is responsible for the upward gaze, and the posterior canal for the downward gaze. Accordingly, the nystagmus that will be seen in the horizontal canal BPPV will be horizontal nystagmus, and in the anterior canal BPPV, it will be downbeating nystagmus, and upbeating nystagmus in the posterior canal BPPV. Here it is the case of a posterior canal BPPV. We can see after a short latency, we can see a upbeating torsional nystagmus towards the right. This is a typical presentation of a posterior canal BPPV. In a horizontal canal BPPV, we usually do the supine roll test, and this is when the patient is sit in a supine position. and the head is rolled towards the right, then we get a left beating nystagmus. Here it is a case of a apogeotropic pattern of BPPV, but I'm just showing that that in a horizontal canal BPPV, horizontal nystagmus is seen. Now, turning the head towards the left side, again the nystagmus reverses to the right beating nystagmus, showing an apogeotropic pattern. So whatever pattern may be, but the nystagmus is always horizontal in a horizontal canal BPPV. Then this is a case of anterior canal BPPV. Patient is brought to a straight supine head extension test, and then observe after a short latency, we'll see a downbeating nystagmus with a torsional component. This is a characteristic of anterior canal BPPV. However, we have to remember that the downbeating nystagmus can also be present in other variants of BPPV, but since my topic is only on anatomy and pathophysiology, we are not going into the atypical presentation of BPPV like otoconia in the crus communi and otoconia in the short arm, where we can also see downbeating nystagmus. Coming to the pathophysiology of BPPV, as we have discussed earlier, that the otolytic membrane, on the top of the otolytic membrane, the otoconia crystals are arranged in a blanket form. Protein fibers connect these otoconia crystals to the hair cells and the dark cells of the utricle, adhere otoconia to the surface, and the dark cells of the utricle are responsible for resorption. So the first step in a BPPV is otoconia losing contact with the utricular dark cells. So to understand this, we have to understand the steps of the otoconial metabolism. The first step is biomineralization of otoconia upon the otolytic membrane. The second is otoconia adherence to the otolytic membrane, otoconia adherence then to the dark cells of the utricle, and then demineralization of the otoconia by the dark cells of the utricle. So any step, any defect in this step will result in otoconia detachment and then causing the pathogenesis of BPPV. So coming to the disorder biomineralization, when can it occur? Disorder mineralization can occur due to excess production of otoconia more than otolith can hold, and also defective feedback mechanism to hold the otoconia production. Disorders of otoconia adherence to the otolytic membrane. When does this happen? This happens when there is a traumatic fracture to the otolytic membrane, or when the otolytic membrane is very fragile. Aging also causes change in the otoconial composition affecting adherence, and high intensity impact to skull also causes detachment of the otoconia. Disorder of the otoconia adherence to the dark cells of the utricle. This happens when the dark cells of the utricles is adversely affected in certain conditions like infection, ototoxicity, and aging. Disorders of the otoconia demineralization. This is the last step. This happens when there is a defective calcium mineralization seen in vitamin D deficiency and also in osteoporosis. So understanding the steps of the otoconial metabolism, we can easily understand why the etiology of the BPPV occurs, mainly the secondary causes of BPPV. Like, for example, trauma can cause, mechanical trauma can cause detachment of the otoconia, and also iatrogenic trauma during surgery, which is created during the surgery, can cause utricular damage and can ultimately leading to BPPV. Aging is another etiology where it can result in the faulty shape of the otoconia formation, and hence enhancing the detachment of otoconia from the otolytic membrane. Vitamin D deficiency will affect the biomineralization of the otoconia. Prolonged bed rest can cause agglomeration and clumping of the otoconia. Since it will result in the clumping of the otoconia cannot remain on the otolytic membrane and it will be easily detached. In a Meniere's disease, also due to the long-standing Meniere's disease, it can damage the utricle. And so if there is a defect in the dark cells of the utricle, then resorption is also hampered, and hence otoconia will be released from the otolytic membrane. In vestibular neuritis, when there is infection of the vestibular neuritis is usually caused by involvement of the superior vestibular nerve and the inferior vestibular nerve. Since the superior vestibular nerve also supplies the utricle other than the anterior and the horizontal canal, so there will be utricular damage. This results in the otoconia detachment. In the vestibular migraine, we can see BPPV due to the recurrent vasospasm, which can result in the damage of the vestibular epithelium. So my take-home message is there are two vestibular sensors in the inner ear, that is the semicircular canal and the otolith organ. And the orientation of the semicircular canal and the otolith organ are responsible for detecting the type of movements. Specialized neuroepithelium is present in the specific site of the semicircular canal and the otolith organ. The plane of the semicircular canal is related to the line of the action of a specific extraocular eye muscles. BPPV results mainly from the defect in the steps of otoconial metabolism. So today's presentation is only on the pathogenesis and anatomy. We'll be further continuing with the other types of the clinical features and the atypical PPV in the further future classes. And my presentation ends here. Thank you so much.
Thank you, Dr. Supriya. You have made a very elaborate presentation on both the anatomy of the semicircular canals as well as the pathophysiology of BPPV, including the secondary BPPVs also. Thank you so much for your presentation. Now we can take up the questions from the chat box.
Before that, can I spotlight Srinivas sir for his expert comment?
Yeah, please do so.
Hello, ma'am.
Hi.
Yes, ma'am. Thank you so much and excellent presentation. And it's a great start. So it is like this is not a one-day game or this is not a T20. So this is going to be a huge long-term game. So and it is a good start for that. Any questions from Surajit?
Good evening, everyone. So there's one question from Dr. Anjan. What is the cause of self-resolution of otoconia?
Now, is he talking about self-resolution?
Anjanda, if you can...
So what I was thinking that what can be the causes of the self-resolution? Sometimes we think that the otoconia comes back to this original position by its own, or sometimes we think it to be a otoconia get resolution. And in some patients, it's seen that after many years also the patient is complaining same. Patient has been complaining of the same issues, same positional vertigo for many years.
Yeah.
So that it persists. But if the solution is that if otoconia get resolved by itself, so the disease should have been gone for everyone.
Yeah.
For some patient, why it persists, and for some patient it does not persist without treatment.
So my personal thoughts are, of course, why one patient persists, other patient does not persist is a little difficult question. But before that is the spontaneous resolution. What could be the mechanisms of spontaneous resolution? One of the mechanism for spontaneous resolution is in our day-to-day maneuvers, we are doing repositioning. In our day-to-day movements, see, basically, who are the people in whom it stays long? The people in whom it stays long is the people who are most scared. These are the people who will lie down so slowly. They will not move this side, they will not move that side. In these people,
this circular canal actually becomes a trap. They will move only so much, only so much, only so much, only so much. So it will not get a opportunity for self repositioning. A person who is not scared, or who person, see, there's a lot of times we have seen general practitioners for what we know as BPPV have simply given 3 or 4 days of some tablets, either chlorperazine or beta-histine or something like that, and they tell I became better. But what is happening is they just removed the fear. After removal of the fear, patient has been doing normal activity, and during one of those bed rotations in the normal time, it just came off. So that is one possibility why it is there is spontaneous resolution. The second reason that there could be non-spontaneous resolution is actual dissolution of the particle, because calcium carbonate, we all know that little bit acidic medium, it just dissolves. So there is a possibility that an acidic medium is induced at some point of time inside, and then the calcium carbonate dissolves, and then it becomes in the canal, in the distant part of the canal. Maybe it is just when you see the blood supply also, the richest blood supply is actually in the ampulla area. The richest blood supply is in the utricle area. The richest blood supply is not actually in the canal duct area. So where there is a possibility that once in a while an acidotic milieu gets established, if something like that happens, then it can actually dissolve on its own. So these two explanations are what I can think for spontaneous resolutions that we see in some people, that the particle itself actually moves or the particle dissolves. So these two things. Please do let me know if there is a lot of background noise which is preventing you from hearing well. If that is the case, then I'll just move to another corner.
No, sir, it's fine.
It's fine? Okay, great.
So it's fine. Now there's another query from Fukan sir.
Yeah.
What is the procedure that has to be adopted for primary and secondary BPPV diagnosis overlaps?
If diagnosis of both primary and secondary, then what procedure has to be adopted?
Procedure as in for diagnosing or for treating?
So he basically wants to know if there's an overlap of primary and secondary BPPV. Is there any way of finding out whether it is primary or secondary, or if there is overlap, which is more important?
See, ultimately, how long will primary BPPVs remain? As long as we cannot recognize the cause. Basically, every BPPV is actually a secondary BPPV. Hello?
Yes, sir.
So basically, every BPPV is a secondary BPPV because there is something else that has caused the inner ear damage, and secondary to that, the otoconia has actually become loose there. It is not happening de novo. When we recognize that cause, then we are calling it a secondary BPPV.
Secondary.
So BPPV to occur per se, there has to be something wrong in the otolith organ.
Absolutely.
So in that sense, every BPPV, it's only primary because we have not been able to locate the cause of the inner ear condition.
Absolutely.
And I think
Yes.
diagnosis and management of BPPV is not dependent on the cause of it being primary or secondary. It is basically on which canal is involved, diagnosis, and then treatment according to that.
Absolutely. Absolutely. As of now. And if you can recognize the obvious cause of secondary BPPV or whatever, if you actually see a nutritional deficiency, identify that and treat that also.
Thank you, sir. Fukan sir, I hope that is done.
Yeah.
We missed
Okay,
one.
this is a question from the big madam herself, Dr. Anjana Sharma, Srinivas boss. Diagnostic maneuver for horizontal canal showing vertical nystagmus. What are the points in favor of still it being BPPV?
No, it is all the points are still in favor of that itself. I will not think of anything other than BPPV. First, I will think of BPPV only. Especially if the nystagmus corresponds to any canal. I am not bothered about.
Anjana ma'am, please unmute yourself and ask the question directly if you want any more clarification.
So many a times, actually, recently I have testing a patient with for horizontal canal. On the left turn, I got a vertical torsional nystagmus. Luckily, I got a torsional component of it.
Yes.
So thought it might be, let me check the left posterior canal there, and it was positive. So if I don't get a torsional component, so should I, it is customary to do the changing of the gaze to find out the torsional to confirm it. It is a it's vertical component of the nystagmus is not central. It's a BPPV. Just wanted to know, how do you check, sir? If I get pure vertical nystagmus.
If you get pure vertical nystagmus, more likely it will be downbeat.
Okay.
Okay, more likely it will be downbeat rather than upbeat. And if you get a downbeat nystagmus, what I will immediately tell you is to rule out a downbeat nystagmus syndrome, put the patient prone. And if the downbeat nystagmus increases in the prone position compared to the supine position, then you are clearly looking at a what is so-called central cause. Okay, upbeat nystagmus only appearing in the supine position and then which goes off after some time is still likely to be BPPV. Okay, and then I know the other question that you asked is, can I ask the person to look right or left to make the torsional component more? But if in a BPPV, it may not last that long, that to give that much of time also, unless you want to do it again, repeat it and do it again. So the approach that I would still take is same. Look for it again. Do a if required, do a Dixalpike also, and reconfirm it. If that is showing something else, then I will bother. Otherwise, I will take the approach as BPPV only. What you luckily did, I would want you to do all the time. Go ahead and do the Dixalpike on that.
Thank you, sir. Anjana ma'am, I think that explains a lot, hopefully. So now again, another query from SB Fukan sir. Which maneuver is better, Epley or Semont?
So it depends on whether he likes Americans more or Europeans more.
I think for a normal canalolithiasis, Epley or Semont is equally good, but we are thinking of cupulolithiasis. I think then we have to go for Semonts.
Yeah, I agree.
Epleys will not act in a cupulolithiasis.
I completely agree.
But for canalolithiasis, as you said, it depends on whether you are an American lover or a European lover.
Yeah. Fukan sir is not releasing the secret.
No.
This is another question from Dr. Hemanta. Is there any
Michael is to be from where?
Europe.
German.
Europe, yeah.
But then he likes that Simons.
He likes
Not
Semons.
the Epley.
No.
He likes
Semons is basically European and Epley is basically American.
American. Opposite.
So there is another question from Dr. Hemanta. Is there any seasonal aspect to BPPV?
Absolutely there. Absolutely it is there.
Is there any explanation to the seasonal variation you can think of?
One of the explanations, there was a paper that came out. One of the explanations was there is a time after a few winter months, towards the end of the winter months when the summer was just starting, those days,
around this time of the year.
Yeah, maybe, yeah. So during the winter, this is a European study. Okay. So basically what they told was, over the winter months, the vitamin D depletion started, and towards the end, the depletion was almost complete. Though the summer was starting, it still did not matter, and they started getting recurrent BPPVs, multiple people having BPPVs because of that.
This is another point being put up by Dr. Anjan.
Yeah.
So what Anjana wants to know is BPPV more common following cataract surgery?
100% yes. 100% yes.
Because of the prolonged position, because cataract surgery does not take too much time. It's only 2-3 minutes procedure. But what
takes.
can be the cause? Because I have also seen so many patients
I have
after
seen
cataract surgery.
so many patients after cataract
Yeah.
surgery. Maybe one of the reasons could be the kind of positioning patient goes back because they have undergone eye surgery on the same day. They are spending more, not turning right, turning left. Maybe that is the reason.
Another
but-
thing that induces BPPV is root canal.
Yeah.
Because of the drilling and everything, it maybe releases otocorneas.
Even people who go to that saloon with that hair dressing, when they go to that hyperextension position, after that dressing, the moment they get up, they get it.
Yes, yes.
Even within that, not even in the next day, in that extended position, they get it. So position has a role.
But what I am wondering about the cataract surgery, but its surgery lasts only for 2-3 minutes.
Exactly. So it is not.
Yeah.
It may not
But
be in
it's
cataract.
not the vibration also. It's not the no vibration, no anesthetic also. Sometimes they use topical. So
Sir,
position also is not that awkward. So
in
why?
cataract, it may not be the surgery. It may be the immobilization after the surgery that they do at home.
Okay, that may be on.
Yeah, because they are generally human beings are moving, chopsing, turning, writing, everything. But the day they undergo eye surgery, maybe that day they are not moving much. They are simply going and lying down straight.
I think there are a lot of papers discussing the relation of BPPV to prolonged immobility.
Yeah.
Prolonged immobility do induce autolytic dysfunction.
Absolutely.
There's a lot of paper to it. Yeah. I think Dr. Smriti, you'd like to add anything? I've been hogging the limelight.
Just I'm waiting for the PGTs to drop in their queries into the chat box. And nice to see the interaction, and it's always a pleasure to hear from Srinivas sir, the master of vertigo. Always a pleasure to hear from you, sir.
Thank you, ma'am. Pratik is there. You can ask some questions to Pratik also.
So, vertigo in all sites, that means in all positions. How will you explain that? Again, a question from SB Fukan sir.
Vertigo
So,
in all positions.
Yeah. Pratik, would you like to take this?
Yes, sir.
So, a patient showing vertigo in all positions, how do you explain that is what SB Fukan sir wants to know.
So vertigo in all the position, or this patient is having nystagmus also? Just one clarification I need.
No
Fukan sir,
nystagmus.
can you clarify? Is only vertigo or there is nystagmus in all positions?
It is the complaint of the patient. He is turning to the front like Namas position or back or left or right in every position, but I have not seen the nystagmus.
Okay, nystagmus has not been visualized, but patient complains of vertigo in any position he is put in.
So while lying down also, while taking a turn in bed also, while standing also.
Left, right, all.
Like all. This could be migraine. This could be lateral canal BPPV also. So now we have to go to the basic, because see, the term which we use, vertigo is a very vague term. We also use giddiness, dizziness, imbalance, brain fog. So we have to be very clear what term we are actually using. Vertigo means it should be actual sense of motion. So you should ask every patient that, do you see that the room or the wall or the fan is moving to one side? If the patient is telling you that this is the scenario, then you can assume that this is actually a vertigo which is induced by inner ears or the peripheral system. If this is the case, then most probably your diagnosis should be horizontal canal BPPV, or in every position, if you are getting an nystagmus which does not correspond to any particular plane or canal, then it could be migraine also. So my suggestion will be, first of all, we have to be very clear which term we use. And second, we have to invest our time in identifying the nystagmus.
How long a person suffers from migraine can he develop vertigo? after how long of suffering from migraine?
Ma'am, patient can complain vertigo for at least 5 days. Minimum is like say 30 minutes. Maximum is like what we have seen is around 5 days.
No, I think
Like
what she wanted to know was, is there any limit like a patient is suffering from migraine, not vestibular migraine, migraine headache or something, and only after these periods of migraine headache, vertigo will come.
Yes.
So, is there any limits or is there anything like that?
during the acute attack, the
No,
patient
no.
will tell.
Is there any relation to, like, has the person need, like a person suffering from vestibular migraine, is it necessary that the person should have a history of migraine headache?
No, no, no,
Exactly. So
no.
vestibular migraine may be the presenting migraine as symptom without any other previous migraine symptom being presented,
Correct, correct,
isn't
correct.
it?
Correct, correct, sir. If
Okay, this is another question. Can we get
ocular
ocular palsy in BPPV?
sir, if you are getting any kind of palsy, be it third nerve palsy, fourth nerve palsy, or abducens nerve palsy, please rule out central causes and don't think that it is BPPV.
Your BPPV cannot have anything like
No,
this because it's a
no, no, no.
pure semicircular canal thing. So it cannot cause ocular palsy. Yes,
BP,
pre-existing palsy may be there, but BPPV per se can never cause ocular palsy. Am I right?
yes, BPPV, the B stands for benign. And getting a ocular palsy is not a benign thing. So always send this patient to a neuro-ophthalmologist, get the eyes checked, rule out any palsy, then get a radiological evaluation done. And don't think that this is BPPV and call the patient again after doing a please. Then you call the patient again after doing a please. You have already wasted 6 days. So don't waste 6 days. Immediately, if you are seeing a disconjugate movement of eyes, immediately send the patient to a neurologist or a neuro-ophthalmologist. This is how
So,
we think.
so another question again, how one can treat BPPV of more than one canal or more than one side at the same time? Multi-canal BPPV. How do you treat multi-canal BPPV?
See, the most common multiple canal BPPV, which is commonly seen is same side lateral canal and same side posterior canal. So the trick is one will be very much the patient will be very nervous in one particular position, or the nystagmus will be more in one direction. If it is more in torsional component and the patient is saying that I'm feeling much more giddy or much more vertigo, and you see that there is a torsional nystagmus, then you treat the posterior canal first. If you think that the lateral canal nystagmus is more, then you should treat the lateral canal first. Wait for a few minutes, like say 15 minutes or 20 minutes. Do a Dixol pike again and check whether the lateral canal has been released or not. So it does not matter whether you treat posterior canal first or lateral canal first. You should treat one by one. Which is more severe, you treat first, then the lesser severe one. And please make sure that you also know the reason of multiple canal BPPV. The most common reason is trauma. And second is central disorders. So you should also keep in mind that rare things are actually rare and more common things are single side BPPV.
So
I think
next question is again, any role in of vestibular rehab in post after performing maneuvers in BPPV?
Sir, there is no role of any kind of vestibular rehabilitation after treating the patient with Epley's maneuver or Simon's maneuver or say Appiani maneuver. Because
This
the
is a
problem
question
is,
from, please go.
the problem is if we tell the patient not to lie down on right side for 2 days, the patient will keep on lying on the left side for 2 months. So they will not understand that this has to be done only for 2 days. They will think that the more I sleep on one side, the more better I will get. So this is a misconception, and you should not tell the patient to lie on one side. This is the mentality of Indians. So I have, like, since 7 years, I have not told any patient to avoid lying on one side. And the only thing which we do is we ask the patient to stand up just after the Epley's maneuver and take a jump 2-3 times so that the particles fall into the utricle. No role of any vestibular rehab exercise after the maneuver.
There's a
So this is a question from Swagata ma'am. Does BPPV ever go away?
I don't know. I don't know whether it. Srinivas sir.
So, Srinivas sir, would you like to answer this?
Continuous remission.
Hello.
So Swagata ma'am wants to know, does BPPV ever go away?
This is the question. This is the question asked by patients also. This is a question asked by patients also. So I will tell you about
At least
one recent patient. He used to get vertigo, I mean BPPV again and again. How many ever maneuvers we were giving, he used to get again and again. Then after knowing about her diet, all this history, I realized that what she was having was some protein deficiency, and then started a turn on amino acids. Now what happened after starting the amino acids is, after starting amino acids, about 2 to 3 weeks later, from then onwards, she is never getting a vertigo attack. But once in a while, she comes. And then she pays the consultation fee, sits in front of me, and then talks, and she goes. I ask, why are you coming? Your vertigo is not coming. She tells, I feel good when I come and talk to you. Okay, no problem. You pay the consultation fees, feel good and go. Like that. So finally, there are going to be solutions. Why I am telling this story is, finally, we are going to find solutions for recurrent BPPVs. As science progresses, we will keep finding some solution. But till then, there are also patients who keep asking, sir, if I get again, what to do? So what I do for this patient who's really worried, what if I get again? Previously, when I was just beginning to do the BPPV work, those days, I used to tell you're cured, don't worry. Now I don't tell them. Now the approach is a little different. Now the way I talk to these patients is, they ask, what will happen if I get again? I tell, first and foremost, realize if I give you cetirizine for a cold, it does not mean that you will not get a cold again.
Yeah.
So you are going to get a cold again. You may get, you may not get. That is different. How careful you are, whatever, still you may get. So like that, it is as simple as a cold for us. It may look so scary for you, but for us, we know that it is actually really as much as that. And the fix is that we need to do the repositioning maneuver. So don't bother. Take an approach take the approach like a cold. Something like that has happened, you come. And I will finish. You know how long it took. So simple. And then afterwards, you are fine. So something like that happens, we are always there. That's all you tell. That is it. This is the now counseling that I am doing. These two things. So finally, the conclusion or the answer for that question, whether does it ever go away? Eventually, we will find answers where things will go away. Things will start going away. Eventually, they will start going away. Okay, it is like that.
Thank you so much. Is there any role of physiotherapist in this case? In any role?
Unless BPPV.
Recurrent BPPV, role of physiotherapist, I really don't know. But there are people with bad necks, okay, not related to BPPV, but then if I find them having a bad neck, then I do send them to the physiotherapist.
Okay. Thank you.
Thank you.
There's an
The next question is from Dr. Kuddush Ahmed. Do birds who have an additional lumbosacral balance organ get vertigo?
I don't know. I don't know. But I like the question.
I think we should all ask someone who is an avid bird watcher. Any bird watcher in our thing?
Dr. Gautam Khan, sir.
Gautam da is, I don't see him here. Gautam da could have told us very well.
He
He's
is
an avid
there
bird
in the
watcher.
group. He is
Even
there.
I don't see Henry also here.
No. Maybe
Gautam da,
somebody
you are
would have
here.
seen.
You can answer.
I have seen cockroaches. Okay, of other things other than human beings. I remember I wanted to help a cockroach which had put itself upside down, and then I go and place it back like this so that it can fly and it can start. It places itself again back upside down. It again places itself upside down, which means its perspective of what is up and what is down had gone. This is my personal experience. So at least in cockroach, there seems to be vertigo. Okay. And in pigeons, fluorines actually induced vertigo.
Yeah.
So fluorines actually induced vertigo and they used to go round and round and round. So those things have happened. So it is quite possible that even in other animals also, vertigo exists, irrespective of how many vertigo vestibular organs they have.
So the next question again from Anjana ma'am.
My problem is you have spotlighted my video and I'm hungry and I'm not able to have food.
So I will change over to the next question. I think you can, this spotlight can be removed and we can go. The next question somebody else may answer. Best maneuver to treat aposiotropic horizontal canal BPPV. I think in the Neurotology Asia group, this is a discussion going on right now. What is the best maneuver to treat aposiotropic horizontal canal BPPV?
The best maneuver is called patience.
So basically what I think wants to know is which is better, doing Zuma or doing Epiani followed by Gofoni?
Actually, now my method of doing this is a little different. I am doing Zumba, but the Zumba lasts 30 minutes.
So a prolonged Zumba.
And with washerman technique. 30 minutes with washerman technique. Okay. There is a 28-minute recording of apogeotropic BPPV, which was treated in one single sitting, but I took 28 minutes to finish that. I was having the VNG goggle, always looking for the nystagmus, checking that it has not got reversed. The therapeutic direction nystagmus has to continue. Throughout the therapeutic direction nystagmus continued. At 28 minutes, we got the full relief. So I have done that. That is washerman technique, Zumba with added washerman technique.
So to everyone, I think very soon, maybe in another month's time, we'll have another session on the maneuvers. So we'll go into the details of maneuvers, what's Epli, what's Simmons, what's Zuma, what Epiani on that. So I'll go to the next question, which is there any particular position there to stay at home is there any particular position there to stay at home while vertigo due to BPPV? Whether it is during the attack of BPPV or after maneuver, I don't understand. But I think after maneuver, I think Pratik has already mentioned there is no particular position. And in before, so if you try to stay in a particular position, you are only not treating it but postponing it. So it's better to immediately take help. This is what I think, isn't it?
Absolutely. I completely agree.
The next question is from Dr. Krishanu. How to proceed in case of subjective dizziness in all direction or multi-direction in a patient?
I think that can be, that is one of the discussions that we had in AOICon Kochi. That itself can be a 1 hour discussion. Maybe
again,
you can
keep that.
Yeah.
Is there any other disease of the sensory organ of semicircular canal or utricle beside BPPV? Question from Dr. Anjan Jyoti Bhuiyan.
Of course, autolytic demineralization itself is a big disease.
Yeah. So it leads to BPPV or it's
No,
other symptoms?
it leads to feet not being on the ground. Our perception of gravity, our perception of our position on the ground, where we are, actually comes from the load on the utricle. How much heaviness is there on the utricle? Simple example, if the lift starts going up, you feel more heavy, where the utricular weight actually increases. Okay, my charging may be around 1% or something. If it goes off, no, it is little more than 2%. If it goes off, then I will start communicating from some other phone. Okay, fine. Okay.
How to differentiate BPPV from triple PD? This is a question from Dr. Manjita Bhattacharya.
BPPV from triple PD is very straightforward, because you make a diagnosis of triple PD when you don't get any of these things. Okay, if you get it, if you go and do the positional test, done. If it is BPPV, you have to know. Knowing whether it is BPPV or not is very straightforward. Whether it is triple PD or not is very difficult. So at least we can be sure that BPPV exists or not exists in that particular patient. All that we need to do is we have to get up from our seat, take the patient to the couch, and do the repositioning maneuver.
So I think a very important question next. How many sittings or maneuver is required, and how often we should do the maneuvers?
Hello?
How many sittings of maneuver is required, and how often we should do the maneuvers?
Generally, it is maneuvers are on the clinic day. Okay, on the clinic day, we generally do the protocol called one wasted maneuver. One wasted maneuver means if you do one replay, we are always going to do one more replay. And if during the second replay, absolutely no nystagmus, no vertigo, that means that was a wasted replay. Then we stop. But if the second replay there was some vertigo, some nystagmus, then that is called that person still had some debris. So I do a third replay. Third time replay comes, then absolutely no symptoms, no nystagmus, then it is considered a wasted replay. So we go up to one wasted replay, then we stop. Then we teach them home cement, and they do home cement for the next 10 days.
Wasted replay is continuous, or you call after a few days?
Continuous, same day. 15 minutes break. 15 minutes break.
And sir, one maneuver should be done for how by the patient themselves, by the attendant at home?
At home, 3 times morning, 3 times night for 10 days.
Okay, total 6 times per day for 10 days.
6 times per day for 10 days.
Thank you, sir.
That is the present protocol that we are following.
Okay, sir.
So, of all the questions, this is the last question. In BPPV, is there any specific findings in VNG?
Of course. We get so much in VNG. In fact, see, basically, previously, we used to actually do so much Dick-Salpike maneuver, that maneuver, this maneuver, so many things. Now, because of the sophisticated tools and the high quality of video recordings that we are getting, even when the patient is asked to wear the goggle and lie down, then itself we see the nystagmus. That is what Dr. Anjana was talking about. She saw nystagmus upbeating, torsional like that, just on supine state. There only you can make a diagnosis in a lot of people. Okay, because of the VNG tools. Then, if the question was, do you get abnormalities other than positional test? Yes, that also is possible. We do get pseudo-spontaneous nystagmus. We do get head-shaking nystagmus. We do get hyperventilation-induced nystagmus, but these are not consistent, but we may get it.
So, there's a corollary to that question from Dr. Suklima Sengupta.
Yeah.
So, she says, is VNG compulsory for BPPV diagnosis?
See, there is always this, I like this term called 80-20 principle. 80% of the work requires 20% effort or knowledge or equipment. But for the remaining 20% of the people, you need the remaining 80% knowledge, effort, instruments, everything. So it depends on what you are targeting. If you're targeting that top end work that I'm not going to miss a single case, I really want to do the best for all my patients, then VNG. It is as simple as, see, when endoscopes came, there were a lot of people who were telling, we are happy with Caldwell look, we are happy with septoplasty. There were a lot of people who told that. There were people who were actually, I've seen them in my own this thing, okay, that there are actually people who have told we can do FES with microscope also. Okay, all of you know. So that was the state. But as days progress, people start adopting, they know that this actual endoscope actually makes a difference, and real great difference. So it is all like that. So now having a tool, very simple. With a indirect laryngoscopy, can't you see a vocal cord polyp? Why are we doing with a 70-degree endoscope or a 90-degree endoscope? That really adds value and it gives that magnified view. You can replay, re-see, do so many things. You can actually see where exactly is the problem. So much is possible, which a few seconds of direct observation would not allow. This recording would allow. So much is there. And then distinct advantage is, if you're doing a bow test and a lean test, in the bow test, you can't be seeing the nystagmus. Second thing is, why is Dixal Pike maneuver designed in such a way? It has been designed in such a way. Why? The reason is to help the examiner be in a vintage position to be able to see the eyes. But if you have the VNG, you don't really need to, most of the time, you can actually make diagnosis even without having to put that to such an extent in a great number of patients. It is definitely going to add increased value. Okay, probably if you had asked me the same question 3-4 years ago also, I would have been a little more equivocal. But nowadays, I'm seeing a huge amount of added value because of VNG. Huge amount. But if you don't have a VNG, should I not do BPPV? No, that is wrong. Even if you have no instrument also, you should start doing BPPV. Even if you help those 80% patients. If they are not there, if you're not getting a clue, then you can always send the patient to somebody who has the VNG.
I think we are already overshooting time. Just 2 questions left. I will stop after this. The first question is, after how much time can the patient be allowed for long journey or traveling following any maneuvers for BPPV?
Immediately.
Immediately is the answer. And the next,
I have settled a lot of.
I think Srinivas, we have lost Srinivas. So he has answered. And the last question was from Dr. Priyanka Chetia. Can we get ocular muscle palsy in BPPV? I think Pratik has already answered that. If you have ocular muscle palsy, it is not BPV, it is something central. So we have to think of that. Pratik is here, he has already answered that.
Srinivas sir's phone has been switched off. Like,
please go on.
Yes, sir.
So that finishes all the questions. So the last question, as I was talking, was regarding again ocular muscle palsy in BPPV. Pratik, you have already answered that. So with this, I think, Pratik, would you like to add anything regarding today's talk and anything?
Surajit, just I want to ask one thing.
Yes, Mukherjee sir, yes.
There are so much of interpersonal variation in relation to the different maneuvers, because some people accept the things, it happens so smoothly, smartly, but others, they take longer time. So much of interpersonal variation happens. I want to know if there is any explanation to that.
Would you like to answer that, Pratik?
Sir, it can be due to the different anatomy of the canals. Sometimes they can be strictures, sometimes they can be canal jam. So these are the most common reasons why we are not getting immediate resolution in few patients, while in majority of patients, like 85%, we generally see that the BPPV, especially the posterior canal, has been resolved. And sorry, the most common thing is we are not doing it correctly. If you
Another
are not
thing,
doing, sir, that
any vitamin D deficiency can cause also something like that, because demineralization question comes, autocorneal get dispersed and all.
sir, it will eventually lead to BPP,
Uh-huh.
but it will not impair the Epley's procedure.
I agree.
Yes.
I
So
agree.
BPPV incidence can increase, but Epley's will work in every patient.
Mhm.
If Epley's is not working in every patient, it means either you are not doing it correctly.
Mhm.
Secondly, is there can be some anatomical variations in canals of different patients. They can be short arm also. They can be canal jam also. So these are the various things. Please remember that you should always focus on nystagmus and the direction of nystagmus so as
Correct.
to arrive at a diagnosis of a BPPV or which side of the canal is involved.
Correct. Thank you.
Yes.
Thank you.
I think thank
Thank
you.
you.
That was the last question. I think I'll request Smriti, Dr. Smriti, to
Wind up.
add her things, and then Dr. Anjana ma'am will wind up.
Mhm.
Uh, so one,
Yes.
it was really nice to have Dr. Pratik also in the conversations, in the discussions, and it was really nice to listen to his explanations of all the questions. And always there's a big thank you to Srinivas sir for all his expert opinions. And it was really an interesting discussion that happened today, because the vertigo is really a very difficult type of a topic. There are many different points to look into it. So there are many things to know and many things to learn. We are all still in the learning phase. I'm now a student of Srinivas sir. So and I'd also request everyone to join those certificate course of vertigo to gain more deep knowledge into dive into the deep world of vertigo and balance disorders. So it was really an interesting topic that was taken up by Nebar Classroom today. And I do believe that we'll continue with the further maneuvers and the treatments in the later sessions. And thanks to Dr. Supriya for her presentation. And that's all from my end. And Dr. Anjana ma'am.
Thank you everyone for joining. First of all, I would like to thank on behalf of NABOY, Dr. Srinivas for being present here and encourage us and giving a lot of information regarding BPPV. And I would like to thank also Dr. Pratik and also moderators, Dr. Smriti, Dr. Surajit, and also speaker Supriya for her wonderful presentation. And I'm sorry we have overshot time for half an hour, but we because already there were some technical issues on Supriya's part, so we didn't stop here. And when Srinivas sir is there, we would like to hear from. Sorry for that extra time. And with this, I conclude this neighbor classroom here. Thank you, everyone. Your participation certificate is there in the chat room, and you can download the certificate. Thank you, everyone, for joining. We'll conclude it here. Thank you, everyone.
Thank you, everyone.
Thank you, ma'am.
Thank you.
Thank you. Srinivas sir is also saying thank you.
Thank you.
Thank you. Thank you.